بسم الله الرحمن الرحيم. مساء الخير على حضراتكم. الحقيقة احنا يسعدنا ان احنا نستمر في النشاط العلمي لقسم علاج الأورام بكلية الطب جامعة اسكندرية. ده شيء بنفخر بيه كلنا، وشيء يعني له أثر إيجابي جدا جدا على القسم. والحقيقة ان حسن الحظ ان النهارده our speaker is my mentor and colleague and brother, Dr. Abbas Omar, and he will touch a very important topic in metastatic colorectal cancer. I think this topic is very crucial for all of us, and I think Dr. Abbas is an exceptional presenter, and we will definitely enjoy a very fruitful night in our scientific activity. Please, Dr. Abbas, تفضل.
Thank you very much, Professor Abdsalam, for this kind introduction. And dear colleague online, I have the honor to present today the role of Beaversumab in metastatic colorectal cancer. This is my agenda. And as you all know, colorectal cancer is the third most frequent cancer and represents 10.2% of all cancer cases in both sexes. Also, it is the second cause of cancer death and represents 9.2%. Approximately 45% of incidents and 52% of deaths from colorectal cancer occur in less developed regions. In Egypt, the incidence of colorectal cancer is 6.1 per 100,000 population, and the mortality is 3.4 per 100,000 population. About 25% of patients present with metastasis at initial diagnosis, while about 50% of patients with colorectal cancer will develop metastasis during their course of disease. And this contributes to the high mortality rates reported for colorectal cancer. The most common site of metastasis are liver, followed by lung, then peritoneal metastasis. And the 5-year survival improved and reached from 13 to 20%. The treatment choice of metastatic colorectal cancer are directed by several factors. For example, patient characteristics like comorbidity, age, the prior adjuvant treatment, as well as the performance status. Also, the tumor characteristic in the form of tumor burden, the ability of resectability of metastatic disease, as well as tumor location, right or left side of the colon. Also, the molecular characteristics, as well the patient preference regarding the quality of life and the toxicity profile of the given systemic treatment. So the therapy of metastatic colorectal cancer is tailored according to individual patients' needs. RAS testing is mandatory test before treatment with anti-EGFR target antibody, while BRAF is a prognostic factor, and MSI testing is predictive for the use of immune checkpoint inhibitors. Other tests are not used in routine patient management. The therapeutic goal in metastatic colorectal cancer differ according to the line of therapy. For example, in first-line therapy, We usually think about the resection of metastasis. What about chemotherapy intensity using doublet treatment or triplet treatment? What about the biological use of biological agent and how many cycles is used, especially with oxaliplatin? In case of response of the first line treatment, we usually think about maintenance and de-escalation of the treatment. Then upon progression of the disease, we usually give a second line with another type of chemotherapy. And if we have a chance to use another biologic agent, we usually use in the second line treatment, taking in consideration the quality versus the quantity of life. And it's very important in this area to look for local treatment like resection of metastatic disease, ablation, radiotherapy, as well as radioembolization. Beyond the second line of treatment in metastatic colorectal cancer, we usually, the goal of treatment is palliative treatment with improvement of the overall quality of life. So it is important to balance potential treatment toxicity against efficacy. It is reported that the median survival increased with increased line of therapy in metastatic colorectal cancer. So we have to give our patient all active and approved agent during treatment. Due to the increasingly complex management algorithm, as well as evolving area of the new treatment, metastatic colorectal cancer should be treated with a multidisciplinary team. This will lead to better patient care and survival outcome. Also, it improves consistency of decision-making and delivery of treatment. Also, there is a benefit of optimal, appropriate, and standardized decision-making on diagnosis, treatment, follow-up, and patient support. What about first and second therapy in such patients? As you all know, 5-fluorouracil is the backbone of the first-line chemotherapy in metastatic colon cancer. And intravenous infusional regimen of 5-fluorouracil leucovorin are less toxic than bolus regimen. Also, you know that capecitabine is an alternative to intravenous 5-fluorouracil leucovorin. And when we add oxaliplatin or irinotecan to infusional 5-fluorouracil, it provides us with higher response rate, longer progression-free survival, and better survival than infusional 5-fluorouracil alone. Folfox and FOLFIRI as a chemotherapy alone have a similar activity but have a different toxicity profile. And you know that K-Box is an alternative to combination Folfox based on similar activity and safety profile. Finally, the exposure of all three cytotoxic agents, fluoropyrimidine, oxaliplatin, irinotecan, in various sequences or in combination may result in a longest survival. We currently have a large number of chemotherapeutic agents and biologic agents by which we can personalize treatment according to our patients' needs. So we can combine doublet combination, triplet combination, or even maintenance therapy with targeted therapy like Beaversumab, cetuximab, panitumumab, and other targeted therapy. Let's start by anti-EGFR in metastatic colon cancer. You know, cetuximab and panitumumab are monoclonal antibody directed against EGFR that inhibit the downstreaming signal of KRAS, BRAF, and Merck ERK, as well as PI3K and AKT, which, when activated, it causes invasion, proliferation of malignant cell, as well as cancer stem cell renewal and differentiation. Several phase 3 trials addressed the role of anti-EGFR as a first-line treatment, adding cetuximab to FOLFIRI, cetuximab to FOLFOX, or panitumumab to FOLFOX, and all these trials showed a significant response rate in favor of adding cetuximab to chemotherapy, as well as improvement in the overall survival, progression-free survival, especially in patients with RAS wild-type tumor. Also, addition of cetuximab to irinotecan in second line showed improvement in response rate, as well as significant improvement in progression-free survival. Comparing head-to-head panitumumab with cetuximab in ASPECT trial showed that panitumumab is non-inferior to cetuximab, and both agents provide similar overall survival benefits in metastatic colorectal cancer, and they had a toxicity profile that were to be expected. So to conclude about EGFR inhibitor, recent meta-analysis of randomized clinical trial concluded that EGFR inhibitor provide a clinical benefit in patients with RAS wild-type metastatic colorectal cancer. Patients with known KRAS NRAS mutation should not be treated with either cetuximab, panitumumab, either alone or in combination with anti-cancer agents. What about Beaver in metastatic colon cancer? You know that Beaversumab is a humanized monoclonal antibody that targets VEGF-A. It binds to the VEGF-A protein, and thereby inhibiting the process of angiogenesis, as you see in this figure. Beaver also prevent binding VEGF to its receptor, and it has a long elimination half-life, approximately 20 days, which may contribute to the continuous tumor control. Also, it exerts multiple effects that contribute to increased treatment efficacy, like regression of existing tumor vasculature, inhibition of new vessel growth, as well as anti-permeability of surviving vasculature, which in turn this lead to increased response rate to treatment, control of the tumor growth, as well as the reduction of ascites and effusion. Beaversumab was addressed in first-line treatment in patients with metastatic colorectal cancer in combination with capecitabine or FOLFOXIRI, or with capecitabine or IFL regimen, as well as in second-line treatment in combination with FOLFOX or other type of chemotherapy. And all these trials showed a significant improvement in the overall survival, as well as progression-free survival. Head-to-head comparison of EGFR inhibitor and anti-angiogenic agent were done in two important trials, the CALGB trial and the FIRE-3 trial. In CALGB trial, untreated patients with metastatic colorectal cancer were randomized to receive Beva plus Fulfoxy or Fulfiri, or receive cetuximab plus Fulfox or Fulfiri. The primary endpoint of this trial was the overall survival, and it was met. There is no difference in overall survival between patients treated with Beva or cetuximab. Also, there is no difference in progression-free survival in patients treated with either Beva plus chemotherapy or cetuximab plus chemotherapy. Also, there is no difference in overall survival or progression-free survival. We use Fulfox or Fulfiri in the whole population of the study. Also, better dermatology specific quality of life with Beva compared to cetuximab, as you see in this figure. As regard toxicity, the grade 3 toxicity were comparable in both treatment arms. However, there is increased skin rash in patients treated with cetuximab plus chemotherapy, as well as the hypertension is slightly higher in patients treated with Beva plus chemotherapy. The other important trial that compared Beva versus cetuximab is the FIRE-3 trial, which randomized patients to receive either Beva plus Fulfiri or cetuximab plus Fulfiri. In this trial, the endpoint is overall response rate. Let's see the result. Again, the overall response rate is similar in both treatment arms, and no significant difference between the Beva or cetuximab when combined with Fulfiri. Also, the primary endpoint was met. There is no difference in progression-free survival between Beva or cetuximab. However, in the overall survival, there is a significant difference in patients treated with cetuximab with Fulfiri in comparison to patients treated with Beva plus Fulfiri. Also, in BRAF mutation, there is no difference in progression-free survival or overall survival in patients treated with either Beva or cetuximab. As regard the toxicity, of course, patients receiving cetuximab plus Fulfiri had a higher skin toxicity in comparison to patients treated with Beaversumab. What is the influence of primary tumor location on efficacy of cetuximab or Beva in patients with metastatic colorectal cancer? As you all know that there are different developmental genetic difference of left and right side of the colon. As you see in this figure, there is a difference in clinical characteristic between right and left, difference in molecular marker, as well as genetic expression. In CALGB trial, as you see here, right tumor had a lower overall survival when treated with cetuximab in comparison with Beva, while in left side tumor, there is a slightly higher overall response in patient treated with cetuximab. And as you see here, there is about 25.7 months difference in the median overall response in patients treated with cetuximab in left side, 39 months versus 13 months in the right side. While in patient treated with Beaversumab, there is just about 3 months difference in the median overall survival between left and right side treated tumor. As regard the difference in FIRE3 trial, overall survival was correlated to the biological agent, Beva and cetuximab. In right side tumor, have a significantly worse survival than left-sided tumor. This difference is more pronounced in tumor treated with cetuximab than those treated with Beaversumab. The progression-free survival in all RAS wild-type patients, according to the tumor location, as you see here, there is no difference between Beva and cetuximab in left side tumor or the right side tumor. In general, the overall response rate in patient with left side tumor is significantly higher regardless the use of cetuximab or Beaversumab. However, in left side, patient treated with cetuximab showed a higher, significantly higher progression-free survival as well as median overall survival in comparison to patient treated with in the right side tumor. So we have discrepant data between CALGB trial and FIRE3 in the form of overall survival. In CALGB trial, the overall survival, there is no difference between Beva and cetuximab, while in FIRE3 trial, there is a significant better survival in patient treated with cetuximab than Beva. So there is disagreement between the results of the CALGB and CALGB and the FIRE trial. Let's see the data of both trials. In CALGB trial, 75% of patients treated with oxaliplatin, while 25% only of patients receive irinotecan, while in FIRE3, all the patients received irinotecan, together with cetuximab and Beaversumab. Also, the right side tumor in CALGB trial was 31.4%, while it is less in the FIRE3, about 22.3% in FIRE3. So there must be an interplay between biologic, cetuximab and Beva, the chemotherapy, whether oxaliplatin, irinotecan, and as well as the microenvironment. Can we deduce from the available scientific data we have the results of the interplay between these factors for each CMS subtype? Before we go to the result, let's know what is meant by CMS subtype. CMS subtypes mean consensus molecular subtypes. They are 4 types with distinguishing finger. The first type is CMS1, microsatellite instability, and they constitute 14%, as you see in this figure. The second is CMS2, Canon 37%. It is epithelial. The third one is CMS3. It's metabolic and represent 13%, while the fourth one is mesenchymal, which represent 23% of the molecular subtypes, and the rest is 13%, which is a mixed feature and represent transition phenotype and intra-tumor heterogeneity. These consensus molecular subtypes are the most robust classification system currently available for colorectal cancer and the basis for future clinical stratification and subtype-based targeted intervention. This table shows some characteristic of the CMS types. For example, CMS1 characterized by microsatellite instability, high, and BRAF mutation, while MS3 characterized by mixed MSI and KRAS mutation. Also, CMS1 carry worse survival after relapse, while CMS4 carry worse relapse-free and overall survival. If you look to the correlation between CMS and sideness, we find that higher CMS1 in the right side, while the CMS2 in the left. Also, there is a correlation between the response to biologic agents, cetuximab and Beaversumab. As you see here, the response to cetuximab is higher in CMS4 subgroup as well as in CMS2, while higher response to Beva is reported in patients with CMS5-3. On the left side, it is characterized by excess of CMS2 as well as CMS4. So cetuximab is effective than Beva in the left side. While in Beva, Beva seems equal to cetuximab in response in CMS1 group. In the right side, so the response in the right side is more in favor of Beva. So there is a difference. Okay. If there is difference in response to chemotherapy between the CMS subtypes, the answer is yes. If you look to this figure, you found that the response to oxaliplatin is higher in CMS2 subtypes, while the higher response with irinotecan occur in CMS4 subtypes. So biologics synergize with oxaliplatin and irinotecan to overcome the tumor-resistant and improve chemotherapy effectiveness in metastatic colorectal cancer. So the response to treatment is dependent on the biologic, like Beva and cetuximab, the chemotherapy backbone, like oxaliplatin, irinotecan, as well as the environment, as we said in the previous slides. So this can explain the discrepancy between the data of CALGB and FIRE3. Another important issue in the management of metastatic colorectal cancer is maintenance treatment, especially using BEVA in maintenance of metastatic colorectal cancer. And we have two important trials that address this issue. First is the CAIRO3 study, in which they randomized patients who responded to initial treatment of BEVA plus K-box. They were randomized to maintenance chemotherapy with BEVA plus capecitabine or observation. And upon progression, patient treated with BEVA plus K-box in both treatment arms. The primary endpoint is PFS2, which is the progression-free survival after reintroduction of BEVA plus K-box. Other secondary endpoints include PFS1, overall survival, time to progression 2 on any treatment, including BEVA and K-box and other secondary endpoints. As you see here in CAIRO3 trial, BFS2 and BFS1 significantly improved with maintenance of BEVA plus capecitabine. Also, the time to progression 2, disease 2, significantly improved with maintenance of BEVA plus capecitabine, and there was overall survival increase with the maintenance of BEVA and capecitabine. The best overall survival was with maintenance therapy was noticed in patients who achieved complete clinical response or partial response in comparison to those patients who had stable disease. About the safety, there is a significant high grade 3 and 4 event in patients treated with BEVA plus capecitabine in comparison, of course, to observation, especially hand-foot skin reaction due to the use of capecitabine, and sensory neuropathy due to the oxaliplatin chemotherapy. Of course, the quality of life was higher in the observation group compared with maintenance of BEVA plus capecitabine. However, no difference in physical functioning between the two arms, the maintenance and BEVA plus capecitabine. The authors of CAIRO trial concluded that the primary endpoint of this trial was met, BEVA plus capecitabine maintenance in patients achieving response on BEVA. K-box significantly increased in progression-free survival and time to disease progression, with numerically increased overall survival. Also, the best overall survival was observed in patients who achieved complete or partial response, and comparable safety between BEVA capecitabine versus observation, except for hand-foot syndrome associated with capecitabine. The second trial is TRIBE trial, which randomized untreated patients with metastatic colorectal cancer to induction chemotherapy using BEVA plus FOLFIRI or BEVA plus FOLFOXIRI, doublet chemotherapy plus triplet chemotherapy, together with maintenance of BEVA plus 5-fluorouracil in both arms. Again, the primary endpoint of this trial is progression-free survival, and as you see, the progression-free survival and the overall survival is significantly improved when we use Beva plus triplet chemotherapy. As regards the overall survival, there is a significant improvement in the overall survival rates in patients treated with Beva plus fulfixiri compared to patients who treated with Beva plus fulfiri. Also, in updated data of TRIBE trial and in unselected metastatic patient, there is a significantly improved of the overall survival with Beva plus fulfixiri in comparison to patient treated with Beva plus fulfiri. As you see here 29.8 months versus 25.8 months. As regard the safety profile, neutropenia, of course, was significantly higher in patients treated with aggressive treatment, triplet plus Beva, as well as a significant increase in the peripheral neuropathy in patients treated with triplet plus Beaversumab. Subgroup analysis, all the subgroup are in favor of treatment with triplet plus Viva, except patient who had received prior adjuvant chemotherapy. Also, the results of TRIBE were reported according to the molecular subtype, as you see here, according to BRAF mutation, RAS mutation, RAS and B wild type. And as you see in this graph, patients with BRAF or RAS mutation have a significantly worse overall survival compared with RAS BRAF wild type population. This is a very important table showing the beneficial effect of Beva plus fulfixiri in all molecular subtypes, the KRAS, RAS, and BRAF, especially in BRAF mutated subgroup, where the median overall survival was 19 in Beva plus fulfixiri versus just 10 in patients treated with Beva plus fulfiri. Also, the median overall survival in wild-type BRAF and RAS tumor was 41.7 months, which is the longest observed survival in the trial. The author of the trial concluded that the primary endpoint, which is progression-free survival, was met. Beva plus triplets showed a significant improvement in terms of progression-free survival, overall survival, with borderline numerical improvement in the overall survival. And apart from neutropenia and peripheral neuropathy, the safety profile of both arms were comparable. Also, Beva plus triplet chemotherapy showed consistent benefits effect across all metastatic colorectal cancer subgroup. In subgroup analysis of TRIBE clinical trial showed that patients with BRAF mutation had the worst prognosis. This important home message, very important for our colleague and for clinical practice in management of metastatic colorectal cancer. For patients treated with oxaliplatin-based doublet or triplet chemotherapy plus or minus Beva, it is reasonable to discontinue oxaliplatin after a period of induction to decrease neurotoxicity. We usually give 4 months treatment for 8 cycle. And if there is a stable or responding maintenance single agent, 5-fluorouracil plus beva can be used until progression of the disease, either symptomatic or radiological. And at the time of progression, reintroduction of the first line or using the second line therapy is an option. And this is the continuum of care of systemic therapy in metastatic colorectal cancer, as shown by NCCN guideline version 2021. Patient with appropriate for intensive therapy, we have beva plus FOLFOX, K-box, FOLFIRI, all FOLFOXIRI. While patient on the left side of the colon with KRAS, NRAS, BRAF wild type, they may be treated with FOLFOX plus cetuximab or panitumumab, or FOLFIRI with cetuximab and panitumumab. While patient not appropriate for intensive treatment, we have 5-fluorouracil plus leucovorin or capecitabine combined with beva, and again, patient in left-sided tumor with KRAS and NRAS BRAF wild type can be treated with cetuximab or panitumumab. Also, the ISMO clinical practice guideline divided metastatic colorectal cancer into 4 groups. The first group, which include resectable disease to R0, these patients are subjected to surgery plus or minus adjuvant chemotherapy, and the aim here, cure of disease. Group 2 included patient, we call it comfortable metastatic disease, in which we can start by chemotherapy, then surgery, and then we aim to cure this patient. The third group, which include patient with unlikely resectable disease and high tumor burden, we usually start by aggressive chemotherapy followed by surgery, and the aim here is long overall survival. And the last group include patients with never resectable disease, and here we use less toxic chemotherapy, and we are concerned with the quality of life of our patient. To conclude our talk, despite ongoing improvements in screening to key, colon cancer remained a leading cause of cancer deaths worldwide. Prognostic and predictor factors include stage, molecular subtypes, CMS subtypes, and sidedness of the tumor. And for patients with metastatic colorectal cancer, systemic chemotherapy with or without target biological agent remained the mainstay of management, providing a significant improvement in median and progression-free survival. In most patients, the goal of treatment are to prolong overall survival while maintaining a good quality of life. But in certain patients with metastasis limited to liver, potential cure can be obtained with hepatic metastatectomy. A multidisciplinary team-based approach is recommended for continued improved results in management of metastatic and advanced colon cancer. Finally, we do our best to identify curable patients early, recognize unfavorable biology, and avoid useless therapy. By this, I end my talk, and thank you very much for your listening.
Thank you, Dr. Abbas, for wonderful presentation. Very comprehensive review of all trial of metastatic colorectal cancer. I think is stone corner for metastatic colorectal cancer is CalGB and FIRE3, and for the maintenance, as you mentioned, the Cairo and the Tribe. I think you nicely review the importance of sideness and the importance of the microenvironment, which are the key point in response and outcome of patient with metastatic colorectal cancer. A very important point that you highlight is MDT. Actually, places which practice MDT are high quality practice places, usually university hospital, high academic standard, and so this means that the patient are in a safe hand, not one-man show, and I think this is very important, and by now it is enforced by the government to have MDT for the patient period to have a targeted or expensive medication. Actually, I have to express my real appreciation for Roche for supporting our scientific program and continuous medical education. And I think the floor is open for questions.
Thank you for دكتور عبد السلام for this nice comments. والله يعني أنا استمتعت بوجودي معاكم والله يعني الحمد لله.
الله يخليك دكتور عباس. متهيألي عندنا بعض أسئلة.
دكتور ماهر صابر طبعا. دكتور ماهر صابر اللي مستقصدني.
أهلا بيك. أنا بشكر حضراتكم جدا وبتمنى إن إحنا دايما نلتقي على خير، وإن شاء الله دايما الساينتفك اكتيفيتي بتاعت الاكود at the top. وبشكر تاني مرة تانية دكتور عباس عمر زميلي وصديقي العزيز وأستاذ قسم وأستاذ علاج الأورام بكلية الطب جامعة اسكندرية، وبشكر روش على دعمهم واستمرارهم في تقديم السبورت للساينتفك اكتيفيتي بتاع للاكود. شكرا جدا.
شكرا دكتور عبد السلام، شاكرين جدا. شكرا
لكم، ألف شكر.